Good morning, everyone. Today's EEG presentation is on ictal patterns and IEDs in temporal lobe epilepsy. Presenter myself, M. Shivakumar, and moderator Ashalatha Madam. The scheme of presentation will go with introduction, IEDs, and ictal rhythms. Coming to the introduction of the temporal lobe epilepsies. Temporal lobe is the most common lobe of origin for vocal seizures, and is the most commonest cause of the symptomatic TLE is hippocampal sclerosis. Can be classified as mesial temporal lobe epilepsy, neocortical temporal lobe epilepsy, and both combined mesial and neocortical temporal lobe epilepsy. Here, this can be understood with this MRI coronal view of MRI image. Here, you can see the collateral circle. This is the collateral circus. Any structures medial to the collateral circus come known as mesial structures of the temporal lobe, and the structures lateral to the collateral sulcus are belong to this lateral or neocortical structures. In mesial temporal lobe, cannot be seen in this section. And the structures lateral to the collateral sulcus form the neocortical temporal lobe, contains a piriform gyrus, inferior temporal gyrus, middle temporal gyrus, and superior temporal gyrus, and also the Heschel gyrus. Coming to etiological causes of temporal lobe epilepsy, it can be classified into lesional and non. This lesional mainly they can see in MRI imaging, but non-lesional can be missed, or non-lesional are usually MR negative, and they pose challenges in diagnosis and treatment. Coming to lesional, the most common cause of lesional is hippocampal sclerosis. Following that, next coming, we have to differentiate the mesial and neocortical temporal epilepsy, because they both they are the origin semiol. One minute, 1 minute. Because both mesial and neocortical temporal lobe epilepsy differs in both semiology and electrographically. The frequency of mesial temporal lobe is around 90%. That is very much common than the neo. And patients with temporal lobe epilepsy have more frequent antecedents like febrile seizures in the neonatal or childhood, early childhood period. And these antecedents are less frequent in neocortical. The age of onset early in mesial compared to the neocortical, seen among adolescents and young adult patients. And the presentation is 5 to 10 years later when in neocortical when compared to the mesial. Both patients, mesial and neocortical, will have aura, but the aura in the mesial are mostly abdominal, like rising epigastric sensation, olfactory and gustatory aura will be there. In neocortical, the patients will have an auditory hallucination or vertiginous sensations, or they can have cephalic sensations, and the aura can be non-specific also. As we know, the TLE is associated with automatisms, but it is more frequently and seen in mesial, and is also early in the seizure within first 20 seconds in the mesial temporal lobe, and the automatisms are rare compared to the mesial temporal lobe in neocortical. Motor manifestations of mesial, as we know, TLE is a hypomotor, comes under hypomotor seizures. But patients will have motor manifestations in the form of ipsilateral automatisms or contralateral dystonic posturing. This is due to propagation. And in the motor features of neocortical are early contralateral dystonic posturing and movements. It can be also secondary due to secondary spread or rapid spread. It can be closely mimic the frontal lobe epilepsy, which is a hypomotor, which will have an hypomotor semiology. So one should be careful while judging the semiologies between neocortical and frontal lobe epilepsies. And secondary generalization is more common in neocortical epilepsy than the mesial. Coming to ictal phenomenon of temporal lobe epilepsy and its use in lateralization. Patients with ictal and postictal aphasia and prolonged postictal dysphasia lasting more than 2 minutes lateralize to dominant temporal lobe, and patients having ictal vomiting, thirst, till cough, till speech, till smile or urination, with patients having bilateral automatism with preserved consciousness, will be lateralized to the non-dominant temporal lobe. Here I will be showing semiology of a temporal lobe epilepsy patient. Patient was initially lying down. Then he felt some aura. In this case, it was a epigastric rising sensation. Then he himself has pressed the buzzer, and he was holding the buzzer, and he continued to lie down, closing his eyes. Then again, might be having continued aura, so he has pressed the buzzer. When technician has comfort testing and asked for the name, he was telling his name, but he's have continued to have this perioral automatism and clasping of his both hands. Continue to have perioral automatisms. Now with bimanual automatisms and chewing automatisms, perioral automatisms. Following, looking confused, but following the commands partially. Continued oral automatisms. Then later recover. Here is another seizure semiology. Patient was sitting and talking to the bystander, sitting quietly, and there was a brief behavioralist, or my patient might have aura. Then he refers to lie down. With behavioral arrest. Calling the bystander and indicating to press the buzzer as he's having continued aura. With posturing of right upper limb. And perioral automatisms. Later have forced head deviation towards the right side and tonic posturing. ATLP, right ATLP, asymmetric tonic limb posturing. With tonic posturing of all 4 limbs, followed by clonic jerks of all 4 limbs. Now, coming to the determinants of semiology of temporal lobe epilepsy. As we know, the semiology depends upon the symptomatic based on the areas involved. It is called a symptomatic zone. It depends upon the site of origin and in other areas involved. See the in this image as a graphical image here in the hippocampus, if seizure is started, electrical seizure onset zone, it can spread to the immediately lateral neocortex or ipsilateral basal ganglia or contralateral basal ganglia. It can also spread to the opposite mesial temporal or temporal lobe. In the same way, this spread to the hemisphere, it can spread to the opposite hemisphere and lead to secondary generalization. This spread from the to the immediate structures leads to the different semiologies. It can be pure hypomotor with only pure automatisms lasting for a few seconds, and it can be a motor phenomenon also if it spreads to the ipsilateral or contralateral basal ganglia, causing the dystonic posturing. Later, even the secondary generalization, as we discussed in the neocortex, it's common in the neocortical temporal lobe epilepsies. Also, we can see that depicting the rate of seizure activity from the mesial temporal or temporal lobe to the basal ganglia, thalamus, and other limbic structures like cingulate and insulo-opercular area. Based on this spread, so the semiology differs. The areas all involved are called symptomatic zone. Symptomatogenic zone. Before going to the IEDs or Ictal patterns, I would like to show this 10-20 montage with the temporal leads. The leads highlighted in the box are the temporal leads. The odd number ones left and the even in the right side. F7, F8 are the anterior temporal leads. T4 are the mid-temporal leads. T5, T6 are the posterior temporal leads. Here we can see in the sagittal image. Here, F7 lies between the anterior temporal lobe and the inferior frontal lobe, and T3 in the mid-temporal lobe, T5 in the posterior temporal lobe, close to the temporo-occipital junction. You can also see this T1 on the left side and T2 on the right side. These are also known as Silverman's electrode. These two electrodes, T1 and T2, also pick from the anterior temporal region. As I said, T1, T2, F7, F8 picks up the anterior temporal IEDs, T3, T4 mid-temporal, T5, T6 posterior temporal IEDs. As T5, T6 are in close proximity with the occipital and temporo junction. If any patients with if posterior temporal IEDs alone or occasional propagation from the nearby occipital or temporo-occipital junction seizures. And T1, T2, also known as Silverman's electrode, they are placed like 1 centimeters above the line drawn from the lateral canthus of the external auditory meatus, 1 centimeter above at the junction of anterior 2/3 and posterior 1/3. Coming to IEDs in TLE, IEDs are generated in irritative zone, which is a intellectual epileptiform discharges are generated from irritative zone. They are identified by EEG, MEG, or electrocorticography. Ictal onset zone may coincide with the irritative zone if IED patterns are highly localized. Like irritative zone or ictal zone can be same if the IEDs are highly localized, and accurately localizing this irritative zone is crucial in epilepsy surgery. And irritative zone does not always contains the epileptic zone. Here we can see the graphical image, the yellow color one. It is an irritative zone where from the seizure onset zone, the discharge spreads to the all of this area, And this is the area where we pick the IEDs. So it can be it is going to be very localized to the seizure onset zone, or it can be very distant, like it can be far like nearby structures also involved. From these involved structures, we can see the IEDs in the EEG recording. IEDs in TLE are can be non-epileptiform and epileptiform. Non-epileptiform discharges are focal dysrhythmia and slowing, and can be epileptiform like tirda and spikes. Here I'm showing the focal slowing or non-epileptiform rhythm. Here this is a bipolar montage of with 10 bipolar montage with sensitivity of 10 microvolts with high and low frequency at 70 and 1 hertz respectively. Uh, Here we can see the slowing in the right, focal slowing in the right anterior temporal region. Continued. This can also, here the focal slowing can be seen in the right anterior temporal compared to when compared to the left side, left temporal. Here we can see the focal slowing. And again in another image also, here we can see the slowing in the left temporal region. Same can be seen in the average also. Coming to the next epileptiform discharge, commonly seen in the temporal lobe epilepsy is TERDA. This temporal intermittent rhythmic delta activity. It is first described by Reher et al. It is an interictal phenomenon, and it is occurs intermittently and rhythmic, and that is a delta activity. Like frequency is around 1 to 4 hertz, and it lasts around 4 to 20 seconds with amplitude of 50 to 100 microvolts over the anterior temporal leads. The electrographic equivalents of TIDA were seen in the anterior lateral temporal neocortex and the basal, which is closely related to the IEDs and ictal onset zones. When the patient is having a definite electroclinical features of TLE, and the patient have IEDs absent, or if the IEDs are distributed bilaterally, this TIDA will help in the lateralization, and it is an epileptiform discharge, as I told. Here we can see this is a bipolar montage showing a sinusoidal delta pattern in the mid-temporal region occurring sinusoidal. Same can be seen in the average, common average montage. Here we can see the frequency is around 1 to 2 hertz delta activity seen in the right temporal region. Similar to that, the other form of delta activity is temporal intermittent polymorphic delta activity. This is also seen in temporal lobe epilepsy, but it is non-specific when compared to TIRIDA. Here we can see in the right temporal lobe, right temporal region, and mainly anterior temporal region, we can see the polymorphic delta slowing around 1 to 2 hertz frequency. Coming to the IEDs, first I would tell about the anterior temporal IEDs, then mid temporal IEDs, then posterior temporal IEDs based on the location, based on the this irritative zone, anterior temporal, mid temporal, and posterior temporal. Here in this bipolar montage, we can see spike and wave discharges with phase reversal at F7T1. Which is a anterior region. Can be confirmed with the corresponding common average, where the maximum voltage or amplitude is seen in the T1, which is an anterior temporal spike. Another EEG with in bipolar montage showing phase reversal at F8T2 anterior temporal region. Corresponding common average, we can see peak or voltage in T2. It is an anterior spike. These anterior spikes were classified by Ebersol into type 2 based on the morphology. This type 1 has a dipolar field. This causes a negative region in the inferolateral temporal scalp and the positive region over the contralateral and centroparietal scalp area. And they are sharp counter and have a steep gradient of voltage. They spike origin is mostly this mesial temporal, but also can be seen in the lateral or neocortical origin. Coming to type 2 Ebersol spikes, they are broad frontotemporal negative field without any positive field. The difference is here there is a positive field in the contralateral centro. Here only frontotemporal gradient and frontal neocortex. Here in this EEG, we can see the Ebertol type 1 spike in the left temporal region, anterior temporal. We can see the phase reversal at F7T1. With the corresponding the peak voltage at T1 and also positive in the centroparietal area. The downward deflecting waves, the positive waves. This is able the contralateral centroparietal area. The negativity is seen on the right side here, seen in the right temporal region, and the positivity is seen in the contralateral centroparietal area. Coming to Ebersol type 2 spike, here we can see the negative waves spikes in the left temporal area, and also negativity is seen in the frontal region also, can be seen in the common average also. The spikes in the temporal and also frontal without any positivity. It's called Ebersol type 2 spike, and it is associated with neocortical, can also be seen in mesial. Coming to mid-temporal IEDs. Mid-temporal IEDs can be seen in mesial and also neocortical temporal lobe epilepsy. Here we can see in this bipolar montage EEG showing the phase reversal at T4, which is a T3, T4 are the mid-temporal. Corresponding common average showing maximum peak at T1, sorry, T4. It's a mid-temporal IED. Another image, another EEG with bipolar montage showing phase reversal at T3. Common average showing maximum amplitude or voltage at T3. This is a mid-temporal IED. Coming to posterior temporal IED, as I already told, it's a red flag if seen in isolated TLE like semiology, should interpret it with caution because it may be propagated from occipital. Here we can see the phase reversal at T501. Similar corresponding common average showing the peak at amplitude at T5. This is a posterior temporal lobe, posterior temporal IED. Then coming to frontotemporal spike. These frontotemporal spikes are seen in both the frontal and temporal. Here we can see this phase reversal in the right temporal T2, and also in the frontal region spikes are seen. Corresponding common average is also showing this negative waves spikes in the right temporal region and also the right frontal region. Frontotemporal spikes are are associated with neocortical epilepsy, and also due to involvement of this frontal and temporal structures. So this is frontotemporal spikes are also seen in the temporal lobe epilepsy, and and also in the frontal lobe epilepsy. This is another EEG in bipolar montage showing the phase reversal at F8T2, and also spike and wave discharges in the F4C4. Corresponding common average showing the spike and wave discharges in the anterior temporal and also the frontal region. To bitemporal IEDs, about this bitemporal IEDs can be seen in about 1/3 of patients of TLE, and also these are mainly seen. Bitemporal IEDs are mainly seen even in the sleep records. Here we can see in the left side and also here in the left temporal lobe and temporal lobe and left temporal lobe. This when we see the bilateral IEDs, can be seen in 1/3 of patients. It can occur independently also. Even if the pathology is one side, the IEDs can be seen in the opposite. But if there is the preponderance, if it's more than centered on one side, this can be lateralization marker. But if the greater degree of bilaterally, then it is a less favorable. Then patient will have a less favorable post-op outcomes. IEDs these mostly bilateral IEDs are recorded mostly during the REM sleep, and wakefulness are more and are more lateralized compared to the NR lateral. So, like few patients will have a very less number of spikes over a prolonged recording. Less than 3 spikes per 24 hours EEG recording. These patients, these oligospikers will have less frequent seizures and less severity compared to, and also later in these patients. Oligospikers also have a good surgical outcome. As a the variants which mimics the temporal IEDs. Here we can see the bipolar montage showing a theta range rhythm spike looking monomorphic and lasting for 1 second. But you can see the aftercoming slower distortion of background. It is a benign variant. It mimics the temporal ID, and we can we think as it's a spike discharges, and we can mislead this as a IED, and these are the wicket waves. Completing the IEDs, they're moving to the ictal EEG in temporal lobe epilepsy. Ictal EEG has a lateralizing value. Ictal EEG is characterized by dynamicity, that is, which evolves over time in morphology, amplitude, and frequency. In patients with MRI negative and also patients having non-lateralizing IEDs with bilateral discharges, Ictal EEG provides a significant contribution towards the lateralization. Before moving to the ictal rhythms, here this ictal rhythm starts when ictal onset zone or seizure onset zone. Here the image, we can see the red color area, seizure onset zone, where we can this ictal rhythm starts, and we can record from these. This is called in ictal onset rhythm. These can be identified by EEG and SPECT, and have a high value of lateralization. Initially, ictal rhythms were described by Epstein and Passia. The classified into type 1, type 2, and 3. Type 1 and 2 are classified as subtypes with A and B and C. Rhythm is a rhythmic theta frequency rhythm, 5 to 9 hertz, which lasts 5 seconds and localized mainly in the subtemporal and temporal leads on one side, and it is strongly associated with the mesial temporal lobe epilepsy. The other pattern 1B and 1C are similar patterns, but one has a positive polarity distributed over the verse and the paras same theta rhythm, and 1C is the pattern for 1B followed by 1A. And second pattern is irregular polymorphic delta range 2 to 5 hertz activity. It is a poorly localized, associated with neocortical temporal lobe epilepsy. 2B and 2C also associated with lateral temporal lobe epilepsy. And the type 3 Ebersol rhythm is as a no clear lateralized EEG discharge, or else they may be no discharge and no ictal rhythm, no rhythm is seen. This is can be seen in both mesial and lateral temporal onset. This type 3 rhythm may be due to the ictal onset local hippocampus, which is deeper, so we can't the scalp EEG, or it can be bilateral due to rapid spread to the opposite side. Here, showing the ictal rhythm patterns. Here, this is a bipolar montage where we can see the slowing in the left temporal region, followed by a monomorphic theta around 6 to 7 hertz in the left temporal region. And next rhythm, here we can see around in the right temporal region around 6 to 7 hertz theta rhythm, which is also seen in the centroparietal area. Can be called as an 1B type of Ebersol rhythm. This is another ictal rhythm. We're starting as monomorphic theta, ranging from 6 to 7 hertz. Here we can see the monomorphic theta pattern over the left temporal region, which is continuing on the left region. Then next, in this it is shown as a rhythm, mainly in the anterior temporal region, continuing as delta later. Here it is started as delta rhythm and continued as this theta, polymorphic theta. Can also seen in the this is anterior temporal leads. This is starting in the right temporal region with delta pattern in the right temporal region, evolving to theta morphology ranging from say 7 to 8 hertz. This rhythm can also be now seen in the centroparietal area, which is a Ebersol type 1B. Later, the rhythm is evolving in the right temporal region and also the centroparietal region. And then it is evolving to delta rhythm. Well, the patient recovers, it is evolved into a delta. Next, ictal pattern. Here in the this is a bipolar montage showing in the right temporal region, started with delta activity ranging from 2 to 4 hertz delta activity, which is evolved to theta rhythm of 6 to 7 hertz in the right temporal region. This can also be seen in the left side, propagated to left side, continued as spiky theta over the left temporal region, evolving into the delta rhythm. Here we can see 2 to 4 hertz rhythm, delta rhythm, same continued delta rhythm. Next pattern, here we can see the theta rhythms in the left temporal region of 6 to 7 hertz, evolving into the first initially monomorphic theta, then spiky theta in the left temporal region, later marked by artifact, then followed by diffuse delta rhythm. You can see in the diffuse delta rhythm. After seeing that episode type 1 and type different rhythms, prototypical rhythms, there are other non-prototypical rhythms seen in temporal lobe epilepsy. LVFA, low voltage fast activity, rhythmic spike and wave discharge patterns, onset marked by artifacts, late sustained or lateralizing patterns. And there can be no rhythm. That is, we have discussed as type 3 episode pattern. Coming to the one of the pattern like this non-prototypical LVFA, low voltage fast activity. Here in this bipolar montage, we can see the low voltage fast activity, which ranges from 15 to 20 hertz. Fast activity can be seen in the left temporal region with the ictal onset, corresponding to the ictal onset. This LVFA can be followed by theta or delta rhythm. Here we can see just followed by a delta rhythm. LVFA is commonly seen in temporal lobe epilepsy, both initial, mainly neocortical lobe epilepsy, and also seen in initial, but it is not have any strong lateralizing value. Next, coming to another ictal pattern, spike and wave discharge. Here in this bipolar montage, we can see the spike and wave discharges starting in this right temporal region. Spike and in the here we can see in the even later followed by delta slowing. Few patients, the ictal onset can be marred by artifacts. So the pattern cannot be. Have to see the evolution. Moments of the will start now. Here we have seen some low voltage theta like low voltage theta like rhythm. Then after 20 seconds or 30 seconds, seeing the sustained theta rhythm. Here there is appearance of theta rhythm in the left temporal region. This is a sustained pattern of theta rhythm seen in the temporal. Then coming to another phenomenon, start phenomenon. In this, this is seen. This is not a pattern per se, but it is a phenomenon seen in temporal lobe epilepsy, where we can see here in this bipolar montage. Here we can a delta to theta range rhythm appearing. Later, it disappears for another 10 to 20 seconds. It appears in the same region here. It can appear here in the same region, or it can be started within the different diffuse spread. It can have a different morphology also. First start is missed, and if we only restart is identified, we may be falsely localizing or lateralizing the rhythm. So one should interpret carefully with 2 to 3 pages ahead of this ictal rhythms. This ictal rhythms can be mimicked by this other benign variants like rhythmic mid-temporal theta of drowsiness, RMTD. Here we can see the monomorphic 5 to 6 hertz rhythm in the left temporal region, seeming to be like theta rhythm, but this will have a sudden onset and a sudden offset without changing of background, and mainly in mid-temporal regions. So it is common. It can be confused with the theta rhythm, rhythmic mid-temporal theta of drowsiness. It will have a frequency of theta. So it is differences are, it will not evolve morphologically, and is that there is a sudden onset and offset. Here in the same can be seen in the common average montage. Coming to the post-ictal changes in EEG. As we've seen in a few of the ictal rhythm patterns have shown, there can be a regional slowing or a diffuse slowing in patients. Around 2/3 of patients of TLE have this regional slowing. There can be a background suppression. Some patients can show post-ictal spikes. These post-ictal changes can be used for local ictal onset is unclear. Coming to limitation, scalp EEG. In scalp EEG, as we have seen in few ictal patterns, there will be excessive myogenic artifacts, mainly because of these patients will have oro-elementary automatisms. So this rhythms ictal onset can be marred by artifacts, or throughout the seizure also they can be marred by artifacts. So the ictal onset cannot, sometimes it is challenging to decide on scalp EEG. Can also we can also have false lateralization in conditions like burnt out hippocampal syndrome, where we lateralize to the opposite side, the ictal onset, and IEDs will be lateralized to the contralateral side. So again, here also there will be a risk of false lateralization. Regarding the IEDs and ictal patterns of the temporal lobe epilepsy, temporal lobe epilepsy is classified as both mesial and lateral temporal lobe patterns. Both will differ in semiology and patterns. So one should delineate this with clinical features and also the ictal patterns, that is IEDs and ictal patterns. So semiology wise, we have seen already discussed the differences, and coming to IED in lobe epilepsy. This anterior temporal lobe IEDs are mainly associated, more specific for this mesial temporal lobe epilepsy, and the mid-temporal IEDs can be seen in lateral and mesial and lateral temporal lobe epilepsy. Coming to the posterior temporal, we have to be cautious, because it is a red flag for temporal lobe epilepsy, as it can be seen in also the temporal occipital, or can be propagated from the occipital seizures also. Coming to frontotemporal IEDs. Frontotemporal IEDs, though the spikes can be seen in the both frontal and temporal, these type of spikes can be seen in neocortical and also the frontal lobe epilepsy. So with help of other EEG, EEG, IEDs and ictal patterns, we should even if we see in frontal temporal IEDs, it can be seen in temporal epilepsy. Then coming to bitemporal IEDs. Bitemporal IEDs can be seen in around 1/3 of the patients can be having the IEDs. Even if patients with unilateral pathologies can have bitemporal IEDs. So if the IEDs are around 70% towards, it can be we can proceed with the surgery. And this bitemporal ID, if they're equal, like 50%, 1:1 ratio, it denotes the bitemporal epileptogenesis, and then patient will have a it's not a candidate for surgery or have a poor prognosis. Bitemporal IEDs can also be seen in, as I said, in pathologies, and mainly in the sleep recordings. These bitemporal IEDs appear frequently. Then coming to this ictal patterns, this type 1, type 2, type 3 rhythms, and also the type 1 rhythms it can all monomorphic theta in the temporal regions, mainly the inferior lateral temporal regions, and also the centroparietal regions. It can be followed delta rhythm, and it starts with the delta rhythm, can be followed by the theta rhythm, which is associated with neocortical. Type 1 is associated with mesial, strongly associated with mesial temporal lobe epilepsy. Other ictal patterns seen in this temporal lobe epilepsy are low voltage fast activity and spike and wave discharges, and the late sustained patterns. And these patterns are also seen less frequently, and they are no, they are also their role for in lateralization is less compared to the theta and delta rhythms, but helps in identify the ictal onset. And we should be cautious with the benign variants mimicking the IEDs or ictal patterns, like wicket waves mimicking the IEDs, and this RMTD, rhythmic mid-temporal theta activity, one can confuse with this theta rhythm, ictal onset theta rhythm. So we should be careful before interpreting this benign variants. Thank you. We are ending the session. Thank you for the patient listening.